Chief of the Division of Nephrology at the University of Tennessee. If you will hold questions till the end, we'll be able to take some questions from both speakers at the same time, and Dr. Seliger will rejoin the dais. Thank you. Dr. Kovas.
Thank you, Dr. Adler, and it's my pleasure to be here talking to you. You've heard an excellent presentation about the risk factors of hyperkalemia and the risk of hyperkalemia, so the question is, what should you be doing? So we'll be discussing the treatment, and the broad objectives would be to review treatment options and to examine the potential impact of new therapies for chronic hyperkalemia, so we'll be speculating a little bit. As you very well know, you can categorize treatment of hyperkalemia broadly in two categories. So you have the acute treatments, which you all are applying in the emergency room or in the inpatient setting whenever you detect what you would be considering severe hyperkalemia that requires immediate management. However, there is also this question of chronic management, which we'll be discussing today, which is concerned more about predicting hyperkalemia, preventing its occurrence over the long term, assuming that it's better off to even avoid these severe hyperkalemic episodes. So what can we do in order to prevent hyperkalemia, to control excess potassium levels in serum over a longer period of time? So an obvious approach is to remove any modifiable causes, which is pretty much, we can call this the bread and butter of nephrology when we see hyperkalemia in our patients. These are oftentimes feasible, but sometimes potentially undesirable. So as you will see as we go over each of these options, there are clinical scenarios where you may not want to choose that option, but you may be forced to do it. So we're not going to go over the pathophysiology of hyperkalemia. We just delve right into the treatment options. So as you very well know, CKD is associated with a host of various metabolic abnormalities, and some of them exacerbate hyperkalemia. One of them is metabolic acidosis, and hence correction of metabolic acidosis is one of the measures that you could and probably should take in order to prevent hyperkalemia. Now, there is debate about the effectiveness of immediate correction of metabolic acidosis to correct acute hyperkalemia. Having said that, you have to consider that there are other benefits of correcting metabolic acidosis. Lately, there's mounting evidence that, in fact, maintaining a normal serum bicarbonate and correcting metabolic acidosis is renoprotective. So, to me, this is one of those interventions where there's very little to speak against it, even if you don't believe in its effectiveness in correcting hyperkalemia, although we don't know much about the long-term effect of it. The second one would be treatment of hyperglycemia. Again, this is one of those no-brainers. We know that in the context of severely elevated blood sugar, that can contribute to the development of redistribution and hyperkalemia, and hence correcting it is good for your potassium and is good for a host of other things clinically. So it's another one of those feasible and necessary interventions. Now, another strategy that you could take is to increase potassium excretion. And the natural way of it, as Dr. Seliger showed you, is through the kidneys. So you have patients with decreased GFR, but you can always nudge the kidney to excrete more potassium, and hence you could use diuretics. Obviously, if you have a patient who is volume overloaded, edematous hypertensive, this is probably a useful and even necessary step to take in order to rebalance their potassium homeostasis. However, some patients may be euvolemic or even hypovolemic, and in these patients, adding a diuretic, especially a loop diuretic, may be counterproductive. And also, in patients with very advanced CKD, the effect of diuretics may be questionable, definitely for thiazide diuretics, and sometimes you may need to use very high doses of loop diuretics, which again increases your chances for adverse effects. The second possible strategy here is to stimulate mineralocorticoid effects, i.e. pharmacologically, to add a mineralocorticoid such as fludrocortisone acetate or glycyrrhetinic acid. As you were shown in the talk before me, the effect of increased aldosterone level contributes to excretion of potassium, and hence if you pharmacologically add this, let's say in a patient who has hypereninemic hypoaldosteronism, you could in fact enhance potassium excretion. Now the problem is that if you believe in the benefit of RAS inhibition, then you're doing the exact opposite. by following such a strategy. Okay, so you could enhance sodium retention, you could increase blood pressure, induce edema, and induce fibrosis in the heart and the kidneys. So this may not be a strategy to follow routinely in all your patients. An obvious one would be to assess medications, and this is a biggie because many of our patients develop hyperkalemia as an effect of pharmacologic interventions. And again, the majority of these medications listed could be considered no-brainers, like NSAIDs. None of our patients should be on NSAIDs, I believe. Heparin, digoxin, these are relatively easily replaced, potentially most patients. Calcineurin inhibitors may be more problematic in transplant patients, where you may or may not have other options. Again, Bactrim and antibiotics, you should have alternatives in most patients. Where we have more trouble is the RAS inhibitors. Okay, because again, we regard these as the desirable class of agents which we would use for renal protection. And whereas they have been studied fairly extensively for renal protection, what's less known is that there may also be a survival benefit from RAS inhibitors, as we've shown recently in this paper, comparing 600,000 veterans, matching those with or without treatment for RAS inhibitors and showing a significant survival benefit in patients who were exposed to RAS inhibitors. Again, these were patients with prevalent chronic kidney disease. So discontinuation of RAS inhibitors, again, unfortunately maybe, happens very often, oftentimes by primary care physicians and sometimes by us nephrologists when we feel that we don't have any other options. But I regard this as potentially an undesirable trade-off where we sacrifice a potentially beneficial medication just so that we can control potassium balance. So how about diet? Again, another common strategy is to refer the patient to a dietitian to be educated about potassium restriction, and that there is a relationship between serum potassium concentration and potassium intake has been shown in multiple studies. Dietary potassium, as reflected by urinary potassium, correlates nicely with serum potassium concentrations, and also in dialysis patients where you can measure estimated daily protein intake from urine nitrogen modeling. There's a very nice and very linear association between serum potassium levels and the amount of daily protein intake. So you could limit protein intake, you could limit certain types of foods in order to decrease the intake of potassium. Now, where the problem comes in is this. Aside from the nice colors on this figure, what you'll notice is that these are considered healthy foods. So if you pick your foods that are rich in potassium, you may be picking the foods that a cardiologist might consider the most beneficial foods for somebody at high cardiovascular risk or hypertension. Now, can you imagine a more high-risk patient group than those with CKD, who virtually all of them have hypertension and are at high cardiovascular risk? And when we restrict their potassium intake, in essence, we may be forcing them in a less healthy or unhealthy dietary pattern. The health benefits of high potassium diet were recently very nicely summarized by Dr. Palmer here in a review in Mayo Clinic Proceedings, and they include a decrease in blood pressure, decreased risk of stroke in observational studies, and some interventional trials to favorable effects on bone health, decreased risk of kidney stones, and also some other benefits with chronic kidney disease, such as higher base intake, less acid intake, and renal protection. So again, by restricting potassium intake, again, we're faced with a potentially undesirable therapeutic compromise, again, sacrificing something beneficial or healthy in order to balance potassium. So then we reach for the big guns, okay? Here we are the nephrologists, so we always have dialysis in our back pocket, which we can apply to the most recalcitrant or severe patients. And I like this slide because it helps to know what you can achieve in terms of a single dialysis session. And albeit this was in only 11 patients, it was a nice crossover design where they quantified the amount of potassium removed in an average patient when applying potassium baths of 2, 1, and 0. And as you can see, and maybe you might expect, that the 0K bath removed the most potassium, namely approximately 80 milliequivalents in one session, whereas the 2K bath removed about 50 milliequivalents in one session. So be aware of this when you treat your hyperkalemic patients. Somebody who might have missed several dialysis sessions may require several repeated treatments in order to rebalance their potassium amount. Now, the problem with correcting potassium with dialysis, and here I'm talking about chronic management and mainly about ESRD patients, is that our strategy, our MO is considered solely with mass balance. Okay, so what we're saying is that what goes in needs to come out, and hence we do dialysis in order to remove a proper amount of potassium over a weekly period, every week. What we're not concerned with is that this comes at the expense of ignoring electrophysiology pretty much, because we're doing this treatment 3 times a week, and what we see is a pretty predictable seesaw pattern where pre-dialytically we have a high and sometimes very high potassium level, which prompts us to apply even lower potassium baths in order to achieve that desired mass balance, and as a result we will precipitously drop serum potassium levels during a very short period of time when we dialyze these patients, and then this is repeated. And let's not forget that this is not happening in a vacuum. We have patients with a very high prevalence of left ventricular hypertrophy. We have patients who may have hypomagnesemia, hypocalcemia, and alkalemia. So this may be a hotbed for arrhythmias, with or without the potassium fluctuations too. Then the second qualm that I have with our chronic dialytic management strategy is that proper prescriptions are not always applied in our chronic patients. When you have an inpatient, you check serum potassium pretty much daily or sometimes more than once a day. Now, how often do we check serum potassium levels in our chronic dialysis patients? Typically once a month. Who's to say that that serum potassium is reflective of the patient's potassium every time the patient comes in for dialysis treatments throughout the month? Yet we apply the same potassium bath every time, 12 times a month, based on that single measurement once a month. Just to bolster the argument that our dialysis treatment may contribute to arrhythmias, there was this smallish study that looked at arrhythmia incidence in the context of the hours from starting dialysis. And as you can see, it sort of increased, then it peaked at about 4 hours, then gradually decreased, and then in the wider interdialytic period, it went to sort of a baseline level. So there may be indirect evidence that during the dialysis, there may be an increased risk for arrhythmias, but I have to admit that the amount of information we have in this area is very, very scant, and we are very much in need of more information and more science. So in the end, we may end up using potassium binders, okay, and that may be the only or one of the more feasible strategies that we could apply. The one binder that's widely available and widely used, and it has been so for more than 50 years, is sodium polystyrene sulfonate, or K-exolate. You may or may not know that it was approved actually formally by the FDA in 1961, based on a study that nowadays would never pass muster. This was in 22 hyperkalemic patients, and bear in mind that this was in an era when dialysis was not yet available, at least routinely, and hence this was presented as a potentially life-saving intervention and when nothing else is available. So these were mostly patients with acute kidney injury, some with chronic kidney disease. It was an open-label trial where a median amount of 40 grams of K-exolate was administered to these patients, and it showed that it was effective in 1 day. It led to about a 1 milliequivalent per liter decrease in potassium, and then over 2 days it was 1.8 milliequivalents per liter. Patients also received sodium bicarbonate and some IV dextrose. Another concomitant trial that was shown in the same issue was in 10 hyperkalemic patients, where they used a strategy of either SPS combined with sorbitol alone, or just the SPS alone. And the interesting finding of this is that, again, SPS was effective in lowering potassium. You see the individual patients here, but interestingly, when they looked at the sorbitol patients alone, lowering happened in that group also. In other words, inducing diarrhea may have had also a good effect on lowering potassium, irrespective of adding the binder. Now, granted, this was in a total of 3 patients, so I don't know how far we can go in conclusions regarding this. A more contemporary study was published just last year in 33 patients. This was a European trial where CKD patients with mild hyperkalemia were randomized to receive SPS 30 grams daily versus placebo for 7 days. And in this study, the SPS arm had a more successful lowering of serum potassium, again of about 1 milliequivalent per liter compared to the placebo group, and not unexpectedly, GI side effects were more common with SPS. So the counterpoint sometimes is that SPS may not work alone. So given the studies that were presented, that's probably debatable. The study that is oftentimes used to argue against it is the study in 6 patients in each group using placebo, resin, and then a cathartic to affect serum potassium levels. And there was no effect from any of the interventions. But what's worth noting in this study is that it was done in normal kalemic patients, not hyperkalemic patients. And the dynamics of colonic potassium transport and the effect of binders may depend on potassium gradient and may only be present in hyperkalemic patients. So I'm not sure that this study can be used to speak against the effectiveness of binders or cathartics. Another issue to consider with SPS, again, the widely used treatment nowadays, is the potential for colonic necrosis. And this has initially surfaced from FDA reports of individual case reports. And there's really only one large study that looked systematically in all patients treated with SPS, which was from the Walter Reed Hospital. They looked at 123,000 adult inpatients, and then they examined separately those who were or were not treated with SPS and matched them fairly nicely to quantify the risk associated with it. They had a total of 82 cases of colonic necrosis in 2,100 patients treated. So the conclusion was that there was a clear association with SPS, but the risk was relatively small. So it was 0.14% versus 0.07%, so about double in those treated with SPS. And again, the nicety of that study was that many of the patients had actual autopsies and pathologic findings to support that this was indeed related to SPS, because they were able to show SPS crystals in the areas of mucosal necrosis from those patients who succumbed to this condition. So we arrive now at the new agents that are available to us or that may become available soon. There are 2 new medications. One is Patiromer, the other one is Zirconium cyclosilicate. Both of them are new binders, oral medications, and neither of them is absorbed. Patiromer is a cation exchange organic polymer, and then Zirconium cyclosilicate is an inorganic microporous compound. And these 2 agents, obviously we're in a new era now. They have to undergo very rigorous testing for efficacy and safety in order to be approved, unlike SPS 55 years ago. I will very briefly review with you the clinical trials that were performed in order to show such efficacy and safety. And I have to emphasize that these were based on biochemical endpoints. So it's showing the efficacy and safety of correcting potassium and controlling it over a fairly, maybe longer extended period of time. Without going into too much details, just wanted to show you that there are at least 4 randomized control trials with Patiromer, total number of patients upwards of 600 in these trials. This particular trial was in patients who were hyperkalemic on spironolactone, who were randomized to Patiromer versus placebo, and showing that the Patiromer group here was more successfully maintained the normal kalemic range in spite of even up-titrating spironolactone doses. So it proved the concept that you were able to maintain a RAS inhibitor and even increase the dose in patients who were prone to hyperkalemia in the face of such treatment when treated chronically, and this was for 1 month with this binder agent. A couple of other studies was this one from Dr. Weir, showing in the first phase the correction of hyperkalemia, as you can see here, over 4 weeks. Very nice correction in the first few days of administration. Another interesting point is that the drop was more significant in those who started with higher levels of hyperkalemia that sort of converged, and then it was maintained nicely in the patients who were kept on Patiromer, and those who were withdrawn, the potassium rose predictably back to hyperkalemic levels. Again, showing efficacy over a period of 4 weeks in this study. And finally, this study by George Bacris, this was not a placebo-controlled, but it was Patiromer administered in patients with mild and moderate hyperkalemia, again showing that the strategy worked in normalizing potassium fairly quickly here, and then throughout a follow-up of 52 weeks, so this was a 1-year study, these patients were maintained in normal kalemic range, and then once the medication was withdrawn, the levels increased again back to close to hyperkalemic ranges. This was all about efficacy, so how about safety? In general, the treatment was considered to be safe, although remember we're talking about 600 patients, so very rare events may not show up in these biochemical efficacy studies. What came up is mainly GI side effects, perhaps as expected given the mechanism of action of the agent, namely constipation, flatulence, and an interesting one would be hypermagnesemia, because Patiromer may not be completely specific for potassium binding. It may bind other cations too. However, it was noted that no clinical side effects of hypermagnesemia, such as muscle cramps, paresthesias, or malignant arrhythmias, were recorded in these trials. And then second, I would review with you the clinical trials available, published for zirconium cyclosilicate. There were two larger trials here with a total number of patients of about 1,000. Again, the concept is the same. Essentially, the patient population was slightly different, with the commonality being patients with hyperkalemia, but not limited to CKD, showing a fairly rapid correction of hyperkalemia. And this is ours here on the x-axis, as you can see, with 3 consecutive administrations of a 10-gram dose of zirconium, and then further decrease here in normal range. And then when these patients were allocated to different strength of the binder, you saw that there was a dose-dependent separation of serum potassium levels depending on which group used which strength. A second study used a similar concept in correcting hyperkalemia using placebo-controlled and then 2 different strengths of zirconium cyclosilicate, showing a dose-dependent decrease in potassium compared to placebo, which showed no significant change from baseline. And again, this happened during the first 2 days. And then during the longer-term follow-up, this was for 21 days, so a total of 3 weeks, there was a separation. When patients were withdrawn and put on placebo, they redeveloped hyperkalemia, whereas patients maintained on zirconium maintained normal kalemia. The probably most relevant side effect that was listed in these clinical trials was edema. About 14 of 237 patients in one trial reported this, and the majority received the highest dose administered, and half of them did not require a change in therapy, and most of them completed the study. The reason there is edema is because potassium is exchanged for sodium, so there could be an additional sodium load that is more in patients who require higher doses of this binder. So what is the future of hyperkalemia management, knowing what we know now and the various treatments that we can apply? In general, we can say that our current treatment paradigms are reactive, so we're waiting for patients to develop hyperkalemia. We may or may not send them to the ER, but then we implement these interventions in order to correct potassium, and oftentimes that involves therapeutic compromises that may not leave us with the best possible outcomes. This may or may not change given the new treatments that are on the horizon. Of course, what we have at this point is clinical efficacy and safety towards chronic maintenance of normal kalemia, and no evidence for clinical consequences of this. So are there any clinical benefits? Are these drugs indeed better tolerated compared to, let's say, Dialysate, which is still much cheaper, but where we have potential for even severe adverse effects, and some patients may not tolerate it well? Is their efficacy better? Could there be new indications? So can we go beyond hyperkalemia? If somebody is, let's say, at high risk for hyperkalemia or has a history of hyperkalemia, could you apply these drugs concomitantly with an increased dose of RAS inhibitors? And you can fantasize about what other potential permutations you can use there. And in the end, would this lead to a change in our treatment paradigms? Could we assume that our outcomes may be better if we could just eliminate hyperkalemia as a thorn in our side when treating patients with advanced CKD with RAS inhibitors? And would that result in better clinical outcomes? And number 2, my pet peeve is, could this lead to a change in how we manage potassium in our dialysis patients? And again, this is just my assumptions here, but in my world, the ideal potassium would be maintained at 4, 7 days a week, 24 hours a day in a dialysis patient. So you would dialyze them with a 4K bath, and you would do everything you need to avoid these seesawing patterns. And with that, I'd be happy to answer any questions. Thank you very much.
As Dr. Seliger comes to join us, we would invite, we have time for a number of questions. Yes.
Hi, how you doing? My name is Josh Ryan. I'm a renal fellow at Mount Sinai. And with the case that was presented in the beginning, I saw the patient was taking furosemide once a day. And with some of these binders, the pills have to be separated 6 hours apart. And that kind of limits TID dosing of medications. So loop diuretics and alkali therapy are two potential treatment options for hyperkalemia. Can you comment on how to dose loop diuretics and sodium bicarbonate if someone is taking a GI resin?
The question was, how do you manage the patient's required drugs, which are often BID and TID drugs, with a medication that has to be separated from other drugs by 6 hours?
It's a good question. So the current FDA mandate of 6-hour separation is very inconvenient. It may come down to choosing between the medications. It may come down to, ignoring it if it's not a medication where you can not afford it. For example, if you talk about cyclosporine or anti-rejection medications, I wouldn't take the risk. They may have to use old-fashioned treatments. From what I know, this 6-hour time period may be narrowed by the FDA, but we'll have to see because there's apparently new data that was submitted to them, so stay tuned.
All right, thank you.
Hi, my name is Akram Al-Makki. I have an observation or a question, whatever you want to put it. I noticed in one of the slides...
Can you speak into the microphone, please?
Okay. Can you hear me better now? Thank you. So I noticed in one of the slides that having higher muscle mass can be protective, while male gender is a higher risk too. So males have higher muscle mass. How can you explain that?
Yeah, no, it's a good question, and the question related to the joint relationship between muscle mass and gender, and in that analysis, they were each adjusted for the other. So one interpretation is that among women, this would be true that women with lower muscle mass are at higher risk of hyperkalemia than similar women who have more normal BMI. But I think that the differences between gender are, at least in that analysis, not explained by the differences of BMI. So there presumably is other factors going on that account for the gender differences besides just the greater amount of lean body mass. And that's about as much as I think we can say given the limitations of the data.
Yeah, so one factor that is known is that men eat more potassium. So potassium intake in men is higher than in women on average. So an additional potential explanation there.
Hi.
Yes.
The data you showed for normal renal function versus...
Can you speak
CKD.
directly into the microphone, please? Thank you.
The data you showed for normal renal function versus CKD 1 or 2, 3, 4, and distinct mortality with a K of 6.
Yes.
Can you expand on that a little bit?
So yes, the question was why was the excess risk of one-day mortality, this was again 1 day, why did it seem to be less in those with more advanced chronic kidney disease? And we struggle with this, and again, I think the caveats are that this is sort of the 10,000-foot view of the problem, looking at an administrative database of 250,000 people, so that the precise etiologies and types of mortality we could not tease out from the data. I think the two most plausible explanations were, again, a relatively greater degree of tolerance in terms of cardiac arrhythmia for hyperkalemia, at least with those who have more advanced chronic kidney disease. It's purely speculative. Again, the second one would be that there's underlying confounding that's not accounted for. So I think, as I alluded to, those who started with normal renal function while they were ambulatory, who ended up in the hospital with a K of 6.5, the underlying acuity of illness that caused that severity of hyperkalemia would have had to be greater than if they started with a GFR of 10. And so that it may just be an artifact of that unmeasured confounding of acuity of illness. But I think we should not conclude that in some way we can ignore the hyperkalemia even in those with a GFR less than 15.
Yeah, my name is Faisal Arif, UT Memphis. I have a question. As we know, in advanced CKD, we are employing these binders more and more to control the potassium. what are the defense mechanisms why they don't cause hyperkalemia? Because we know the only major excretion is through the GI, as it is limited through the renal tract in the advanced CKD. Hyperkalemia in these...
So was the question about the binders causing hypokalemia?
Yeah. Yes.
Okay. Yes. So that's a very good question, and it was a concern in these clinical trials. And interestingly, very, very few, to almost no patients developed hypokalemia in these clinical trials. And you may want to go back to that study that I showed you with those 6 patients in each arm, where the administration of a binder or a cathartic did nothing to serum potassium in patients who are normal kalemic to start with. Now, what we know about the GI physiology of potassium transport is very, very weak and a low amount of information coming from studies done mostly in the 1950s. What's worth noting is that the amount of potassium excreted through the GI tract is fairly steady and fairly low. So we're talking about in the order of 10 to 20 milliequivalents a day total. So there is a limit to how much you can remove there, which may increase only when you're hyperkalemic, because you increase the gradient. So chances are that when you become normal kalemic, the amount of potassium that you can nudge through the GI tract is fairly low, unless you have profuse diarrhea, for example.
Thank you.
Normal individuals increase their potassium level during exercise. Usually we are looking at potassium in patients at rest. Could there be an impact of excess mortality related to non-end-stage kidney disease during exercise?
Yeah, that's a really interesting, fascinating question, and I'm actually not aware of any data, at least epidemiologically. Most of the studies that have looked at the mortality associated have, it's just been the long-term mortality, not the specific indications. Yeah, but I'm sorry. Very good question, yeah. Definitely needs to be looked at.
Hi, I'm Caitlin from Decision Resources. It's a bit of a loaded question, but do any of you have experience with Patiromer?
First-hand experience with Patiromer?
Yeah, prescribing it.
I don't.
Yeah, I have not prescribed it now. I practice predominantly in the VA, where it is available, but it's under restricted use.
Me too. I'm primarily a VA physician, so maybe Dr. Adler has...
Just to show that there's absolutely no bias in this symposium, neither have I.
Okay, thank you.
Okay, well, I thank the speakers and I thank the audience for a successful symposium.
Great, thank you.
Thank you.